I had one of those. Okay? Common. Very common. Moving onward. Conservative treatment of the neuroma, including corticosteroid injections, padding, taking pressure off, ice, getting rid of your Cole Haan shoes. Surgical options, you know, simple and revisional. I got to be frank with you. This is something I've changed in my career, and you know, I haven't changed much because I'm doing a good job. But this is something I've changed. I've started to make space for the nerve, which is called like a neurolysis procedure, rather than actually removing the nerve. Now, there are some cases where you can get the neuroma early enough and it responds to conservative care. But if it does not, you're really left with removing it, which is really a neurectomy. And we all are aware that neurectomy procedures are unpredictable because they are removing a nerve. And you're not really able to decide definitively what the outcome is. So another more modern approach is to simply make more room for it, like we do with carpal tunnel or tarsal tunnel syndromes. And that seems to be working quite nicely. You know, even with neuromas that look quite big, I've been making space for them. And patients seem to be doing well. So that's a new trend. But the old tried and true is to cut the thing out. And that's a picture of it right there. Oh, that's a picture of that right there with the nerve and its big fibrosis. Take it out of the foot. That person will get numbness at the affiliated space, but not all the way, just at the bottom section of the foot and toes. And that's usually a happy trade to get rid of the painful neuroma.
You mean the underside of the foot?
The underside of the foot, yes. Any questions? Can you hear me over there?
I can hear you.
Good. Am I talking loud enough for you to hear me?
Yeah.
Yes, you are.
Please say yes.
We are sorry you don't have the foot cookies to enjoy. They're going over quite well. We're moving on. We're about to take out the martinis. I don't know if you can see that or not. All right, here it is. The mother of all foot problems.
Yes.
Plantar heel pain, plantar fasciitis. Burdensome. Plantar fasciitis is the most common condition of the foot and ankle that can occur. We have several terms for it, plantar fasciitis being the most acceptable and common term. Plantar fasciosis, heel spur syndrome. The causation is 4 in number: mechanical causation, neurologic, arthritic, trauma, yada, yada, yada. But, bar none, the cause is mechanical. Okay? All this other stuff is remote, very remote. It's mechanical causation in upwards of 90% of the time. Got some pictures on the side here of plantar fascial anatomy. It's basically a fascial band that goes from the heel to the toe area. It's not a ligament. It is not a tendon. It is fascia. It goes from bone to soft tissue. I guess if it went from bone to bone, we could call it a ligament. But it does not go bone to bone. It goes from bone to soft tissue, and it is made of fascia. If you go through the bottom of the foot, first thing you'll see is skin, then some fat pad, and then you will see the fascial band. It's a big sheet of tissue. Subjective findings of plantar fasciitis. Pain in the morning or after rest. Pain gets better after initial use and may return with lengthy activities like during nursing on firm floors.
Yes.
Yes. No visible swelling or history of trauma or injury. The objective findings are pain on the bottom of the heel, obviously. And I like this slide because it shows the different percentages of where the heel pain occurs. It's kind of confusing, but in a nutshell, 85% occur in the heel. Differential diagnosis. We take an x-ray. Even though it fits the clinical scenario so well, I once had this patient back in like 2000, and they were treated exhaustively for heel pain. And it really, this one didn't fit the bill, so I was like, wow, did anyone x-ray you? And they said, no. Didn't I look special when I found this bone tumor on this guy? See? So instead, I did a bone tumor resection instead of barking down the treatment for plantar fasciitis. Yes. So x-ray is prudent and appropriate. Don't forget them. Visible swelling is suspicious for a stress fracture, which is defined when we squeeze the heel bone. So if you have someone that's a runner, a very athletic person, you know, it could be a stress fracture and you want to take an x-ray. Plantar fasciitis is more remote in children. We almost never see children with plantar fasciitis. Usually that's called apophysitis, which is in fact an inflammatory condition of the open growth plate in the heel. Nerve-based pain will be more sensitive and worse at night and have nerve qualities like radiating, tingling, and burning. I did such a good job making this slide up. In any sense, nerve-based pain can come with plantar fasciitis because the medial plantar nerve is right underneath the fascia. So that's where I think how this nerve thing evolved, but nuts and bolts, it's probably plantar fasciitis if you have heel pain. This is another slide that I made up not that long ago because I lectured on heel pain syndrome not too long ago, in May actually. And I made this slide of protocol. So the protocol is all consistent with what I do within all the practices. And basically it's a combination of stretching, anti-inflammatories, and supportive. And I don't want to burden you guys too much because we can't spend so much time on this stuff because we have the AOR and meeting coming up after. But stretching direct, like rowing on a tennis ball. Indirect, Achilles tendon stretching, night splints. And physical therapy trial. Anti-inflammatory, which is basically ice. Your non-steroidal anti-inflammatories. And again, physical therapy with ultrasound as well as injections. Ouch. Supportive inserts are appropriate. Structured shoes. Non-painful Colhans are a good choice for that. Taping and orthotics. Okay? So let's get to the good stuff where you guys work, the surgical options. In 2010, the American College of Foot and Ankle Surgeons put forth a protocol, and they did a big study on evidence-based medicine and what was the appropriate surgical procedure. And it's really a minimally invasive surgery to minimize scar tissue and so on and so forth. And certainly an endoscopic plantar fasciotomy or a mini open procedure is what the standard is. And in this case, I have a picture of an endoscopic procedure, which I did. Basically, the fascial insertion is found at its attachment on the heel, which is a 3-finger breadth from the back of the heel. There it is. An obturator and cannula are then placed just underneath the plantar fascia. The obturator is removed, and after visualization is achieved with an endoscope. It's so good because you guys know all these terms. Endoscope, cannula. A retrograde cutting instrument is introduced from the inside, and literally a measured 1/3 of the plantar fascia is resected or transected. And this has a high degree of success rate. That's me measuring the exact quantity of transection, and then obviously the procedure progressed from there. This is my son Nicholas. This has nothing to do with the lecture, but it's a nice break. That was his first haircut.